लेकिन वही है कुछ एक स्टाफ को कर रहे हैं।
सर आवाज क्लियर नहीं आ रही।
नहीं चेंज तो डीएससी बैठने से ही होगा। ठीक है मैं ले लेता हूँ। हाँ मैं से बात भी कर लेता हूँ। नेहा मैम मेरा ज्वाइन करेंगे।
नहीं सर प्रॉपर नहीं आ रही।
बेटी नहीं
आप सर है ना ओके
आ गई सर आ गई। मुझे लग रहा है कि कुछ जो लोग नहीं प्रेजेंट कर उनसे रिक्वेस्ट करना होगा कि वो लोग जब तक सवाल जवाब ना हो तब तक वो ऑफ कर के रखें।
ये सर बिल्कुल
मैं यही कह रहा हूँ कि सवाल जरूर
सर स्टार्ट करते हैं वो सर स्टार्ट करते हैं इसलिए हम 6-5 का टाइम रख दिए थे यूट्यूब पे तो वो लाइव चलने लगा वहाँ पे।
मैम कैन वी स्टार्ट द प्रोग्राम मैम?
अशोक भाई सबको मिठाई बात।
हेलो
Hello, Arif. Dr. Bakhla is joining. Actually, he was having some problem. I think he'll join within a minute. I was arranging that.
ओके
ये हटा रहे हैं नमक नमक मिठाई में कैसे करना है
नमक सर भी है सर प्रणाम।
हेलो हेलो हाँ मैम यस यस मैम हो सकता है मेल आईडी गलत है मैं आपके इसी नंबर पे आपको लिंक भेजता हूँ पर
कौन सर पूरी टीम अभी तक वाइट में पूरी टीम अभी तक वाइट में है। सर भी आदित्य सर भी गौरव भी दिखा हमें वाइट में।
हमारे साथ
औरों को बोलो लाइट जला
पूरी 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 फुल टीम है। आदमी दोनों है ब्लैक वाले
और ज्यादा बोल रहे हैं हम लोग गलती मार लेते हैं।
सर गौरव आप तो मुझे बताइए हेलो
अरे अरे गौरव अच्छा बोल नहीं पा
मैम मैंने सिंपल मैसेज भेजा आपको टेक्स्ट भेजा इतना देर वेट करेंगे वहाँ लाइव चल रहा है सब छोड़ देंगे ना डिलीवर कर देंगे
पहले विजय सर का अब बाबा सर क्या
सर क्या करना है
अच्छा
Actually, Dr. Bakhla is still having some problem. So what should we do, Dr. Vijay?
आप ऐसा नहीं बता सकते।
सर वो कर
तो हम लोग कोशिश कर रहे हैं उनका हो जाए। वो पता नहीं कैसे ज्वाइन नहीं करते लिंक तो सेम ही है but he is having some problem.
हम तो पहले
विकास
विकास
यस सर यस सर
विकास
जी सर
विकास एक बार सर को ना रीसेंड कर दो मेल में।
नहीं अभी हमने भेजा है उनको फिर से दोबारा भेजा है।
गोविंदा सर
या हम लोग फिर फाइट तो क्या करें, मेरे को समझ में नहीं आ रहा।
मैम हम लोग शुरू कर सकते हैं क्योंकि ऑलरेडी यूट्यूब पे लाइव चल रहा है।
शुरू कर लेते हैं और जब यहाँ आते हैं वहाँ से जो ब्रेक होगा उसमें सर अपनी बात करेंगे।
हाँ
सम अप कर लेंगे, दैट विल बी बेटर।
हाँ ओके।
सर प्रशांत कहाँ पर है? बहुत दिन से बात करना है।
आ गए सर, आ गए।
ओके आरिफ, देन वी कैन स्टार्ट।
ओके मैम।
सर
सर ज्वाइन
कर ली। एक्चुअली आयुष वाज लुकिंग आफ्टर हिम। ओके
Very good evening all of you. Madam, shall I start?
या यू ऑलरेडी लेट।
In announcements in this floor. First of all, I would like to welcome all the distinguished guests, speakers, and all the participants for today's webinar. First of all, I would like to welcome Dr. Manisha, Associate Professor, Department of Psychiatry. We are great.
आरिफ सर में कब करेंगे?
Ma'am, as we all know, this is the sixth academic program, program webinar. Sir is an associate professor and head of the Department of Psychiatric, RIMPS, Ranchi. Sir has done his DPM and MD from CIP Kanti, and sir has many national and international publications. I welcome you, sir, for today's webinar. Today we have Dr. Vijay as one of the speakers with us. I would like to welcome on behalf of the Department of Psychiatric Social Work, Dr. Vijay is a consultant, Department of Psychiatry, M&SP group of hospital, Muscat, Oman. He has also done his MBBS from Ranchi, DPM and MD from CIP Kanti Ranchi, and he has also worked at RINPAS, CIP group of hospitals. I welcome you, Dr. Vijay. I would also like to welcome Rucha, Bapat, consultant clinical psychologist, is working in Pune. She has also done input from CIP Kanti. She is trained in progressive muscle relaxation and guided visualization technique. And she has also presented many papers in various seminars and conferences conducted. She was also working as a research officer for the project that was a study on physical, sexual, and psychological another speaker with us, Mr. Gaurav Giri, is working as a PSW tutor at CIP Kanti Ranchi. He has done M.phil from CIP and he was doing his PhD from RINPAS. He has also had many publications and he has also been speakers in various conferences and seminars. And he has done his master from Kashi Vidyapith and he was a gold medalist. I welcome all the speakers for today's webinar. So, before inviting the speakers and the delegates for their talk, I would like to say a few words on today's webinar. As today's webinar is on adolescence, I would like to focus on the relevance of today's webinar, that is on adolescence and addiction. As we all know, that adolescence is a phase of rapid growth and development, and physical and psychological and physical changes in life, such as motivation, cognition, control, emotion, and social orientation. And we know that adolescents are the young people aged between 10 to 19, and it is a transitional stage of physical and psychological development from puberty to legal adult. And we know that they constitute more than 1.2 billion worldwide and about 21% of Indian population. And India has the largest population of adolescents home to around 2.3 million individuals in India. And according to the prevalence study, that is around 13.1% of the population people involved in substance use in India are below 20 years of age. So we can, so this, we can say that India has a risk population vulnerable to substance abuse and addiction. As the young and growing children have a poor knowledge and lack of awareness about physical and psychological changes that occurs during adolescence and illness development. And the prevalence of sexual abuse, violence, are increasing among the adolescent youth. And we also know that adolescents are known to have a tendency to be more and greater risk than the individuals in other age groups in many life domains, such as unprotected sex, criminal behavior, dangerous behavior in traffic, experimenting with using alcohol, tobacco, legal and or illegal drugs. Today, no part of the world is free from addiction. Fast spreading each and every corner of the world. The increasing population and nuclear system in the families in India is also bringing a shifting factor in the safety and cultural values. When we say the impact of addiction on children, definitely drug addiction has an impact on the whole family. In spite of being aware of harmful effects of the substance use, adolescents take up their habit. There are several psychosocial factors that have been associated with substance use, particularly where there is a peer pressure, media portrayal of substance use, by celebrities, the lucrative advertisement, then we have attractive packaging and the expectation of joy are commonly associated with the harmful use of substance. And in general, it is widely expected that the peers, the social environment, the family, and the subjective factors play a vital role in the substance abuse behaviors among the young
हो
population.
गया
And these problems can be areas of
बस 2
counseling,
मिनट का है
hospital,
नहीं
psychological, family, psychiatric. There are a lot of psychosocial factors associated with addiction. And these and they have a profound impairment and loss of physical health with people of alcohol and drug use disorder, and they may suffer severely from various psychosocial problems, interpersonal problems, difficulty in participating. So, thus, it can be said that adolescent youth behavior does not occur in a vacuum. There are relevant social ecologies that affect adolescent behavior, including family, peer, social, and neighborhood context, and is required to provide a more complex understanding of the substance use ecology. So, I hope that today's webinar will be fruitful to many of us in understanding the problems associated with the addiction among adolescents, as we have an eminent speakers to address this issue. With this word, I request Manisha ma'am to say a few words on today's webinar. Ma'am, please.
Thank you, Arif, for giving a very very well. You have given the introductory part of this today's webinar. Good evening, each of you who all are going to participate in this webinar, and especially the speakers, Dr. Vijay, Rucha, and Gaurav. Sorry, and our chairperson today, Dr. Bakhla. Thank you very much for giving your consent and sparing your time to conduct this session on the addiction, a slippery slope that Vijay has given us, the topic, today's topic. Thank you very much, Dr. Vijay, for organizing all these things. I'm just a facilitator today. And you have done everything. Actually, I am not aware of any what are the things which is going to happen today. But that's very the purpose behind organizing this academic deliberation is that since we all are not in contact, regular teaching mode is not taking places, and our students are still not getting a quality teaching and information and all. So we thought that we can have this platform through which we can connect with them and give them information and make them enlightened into the various topics that they need to understand. Apart from that, today that we have invited many people also. There are teachers from the schools that we have invited. We have also invited persons to connect with us because this topic itself is such an alarming topic, alarming thing that media can play a very significant role in generating awareness among the adolescents, the family, parents, and school system, how to identify the risk and protection factors, how we can help so that Vijay, that the part of it, you said that slippery slope can be stopped and people, adolescents can be helped not to get into all these activities. And this, I think, your deliberations and the team with the team you're with the deliberation, this will definitely help us in understanding all these risks and protective factors, how we can deal in future and make people aware, even the parents, because what I think is this age group itself as an experimentation is one of the reason why they get into it. That is the curiosity, peer pressure, or emotional distress. Whatever, there can be many variant reasons why they get into it. These are the things which I think that as we will get to hear you all, these things are going to come up. So it will not take much time, and I'll just hope that the participants will be very benefited because it's going to be a very rich deliberation from all of you, and the chairperson himself will be giving a very good summarization of the whole thing. So all of you, I'm very thankful for giving your consent and giving us this opportunity to hear you all. Thank you very much. Thank you, Arif. Over to you. And please.
Yeah, ma'am. Thank you very much, ma'am. Now I request Dr. Ajay Bakhla, sir, to say a few words and also to raise this occasion, sir. Please, sir.
Okay, thank you, Arif. Thank you, everyone. In fact, welcome to this webinar on addiction. Basically, I will not. I will speak in the last conclusion. I will not stop. But basically, the outline is that Dr. Vijay will talk something about concepts of addiction, especially in terms of biological context. Rucha will speak on psychosocial risk and therapeutic modules, and Gaurav will speak on social and family context of addiction. So, preferably, I will request Dr. Vijay to start, and last we have some. In fact, Vijay will conclude in the last some, and there we can have some questions also, and we can. So I request Dr. Vijay to start.
Thank you, sir. Now I request our first speaker, Dr. Vijay, to give a talk. And there's an announcement for the participant. During the presentation, you can ask any question in the chat box. After all the three presentations, at the last we will address the question answer session will be there. I request if any question, just type it out in the chat box. With this word, I request Dr. Vijay to please start his.
Thank you, Arif. I'll start with an anecdote which happened when Manisha ma'am asked me to do this. I reached Dr. Bakhla as a chairperson running, and he was like, home or academics? So this started on this note. So you can understand how strong academic bent I carry and my reputation with my chairperson. When he asked for academics, so why I was so keen? Why I was so keen? There are two reasons. First of all, if you go back to my slide, I would like you to reach my slide. So let's start with that. So if you go back to that, I very purposefully kept it in a way that you can see my designation. So it's ex-senior resident CIP RINPAS. So why I was so keen? First of all, I was getting an opportunity to connect to you all. It's always a pleasure. So that was the first reason, but that would not be the reason if I nice say. So how it was going, like the most important part and most significant part was in my journey where I left from CIT and RINPAS. What I was able to add to my knowledge. This was one of the branches where I thought that I could add up to my knowledge. Knowledge not in terms of answers, knowledge in terms of more of questions. So I was full of questions. I am full of questions. I will be full of questions when it comes to addiction, and addiction more so in a brain which is growing makes it more difficult. So let's start with a series of questions. Uh, Prashant, one of your colleagues was telling me, "Sir, question to like पूछेंगे." I told him my question is खुद से भी दूसरों से भी. So let's start with the question. First question will be, what is normal? So a few facts here and there. Is it normal? Uh, Once in a while, opportunity to go and gamble, is it normal? Or a few hours of video games on the weekends, is it normal? Let's see. So when we are talking about the series of behavior, where it can be experimental, it can be recreational, social, where it can be situational, or as intense as it goes, compulsive. So we are talking about something sinister, we are talking about something in continuum, and that's why the question becomes very difficult to answer. And that's why the acceptance also becomes very difficult, and that's why the whole process of denial. So we'll start with another question. What is that? Addiction derives from the Latin word addictus, legal term referring to enslavement of lessons. Gradually, over the course of time, it was used to capture the concept of loss of personal control before being used as clinical entity. But again, confusion was only increasing. There is a, if you go through a Humpty Dumpty story, when I use the word, it means just what I choose it to mean, neither more nor less. Still, so addiction with various debates, still a confusion what actually this term encompasses, and that confusion still reflects in DSM-5, the latest nosological entity. But few things are clear. What are the central features? What are the central features of addiction? So there is a compulsive engagement in a craving or repetitive urge state, diminished control over the behavior, continued engagement in the behavior despite adverse. So these are the core features where we can say that yes, we are talking about addiction. Since we have been always going through ICDs and DSM, we minded dependence and tolerance are neither necessary nor sufficient for the compulsive engagement. Compulsive engagement itself is the problem. I hope I'm making sense. So, what actually addiction simplifies? What it signifies? It definitely differentiates a point or state from the drug denial. तो एकदम पक्की बात बता रहा हूँ, ये ड्रग नायक स्टार्टिंग पॉइंट से अलग कुछ है, no confusion. A point partway down the slippery slope of increasingly compulsive intake or a point of winning. एक बड़ा क्वेश्चन मार्क डाला है ताकि इस पे emphasis डाल सके. A point of, is it a point of no return? Let's see it again. So why won't get it? होता क्या है? What's going on? There are multiple etiological theories. वहाँ की के कहानी जैसा. There are multiple etiological theories. First one is complement rather than mutual. I'll be discussing few of the speakers. Other speakers will be covering it. And Gaurav. So we have a comprehensive picture of what we're doing. Now let's decipher the brain. It's important to understand. It's important to understand the behavior of addiction. The brain is still the oldest part, and what it was serving for, it was responsible for automatic survival. reemphasizing automatic survival. मतलब जीने के लिए जो करना उसके लिए ब्रेन आसान है समझना, जीने के लिए जो करना था उसके लिए ब्रेन ठीक है, आसान है समझना। अब जरूरत क्यों भी कुछ बदलाव लाने, why was needed some change, why nature was looking for some change। मैं यूं चलूँ, अब कितना ज्यादा एक शेर क्यों 50 किलोमीटर 100 किलोमीटर जंगल में घूमे खाने, एक टाइगर क्यों एक टिग्रिस को ढूंढने के लिए 200-300 किलोमीटर पूरे जंगल में घूमे, वाई क्यों करें। तो नेचर को आपको सर्वाइवल चाहिए था, नेचर को सर्वाइवल चाहिए था, नेचर ने सर्वाइवल को जस्ट सर्वाइवल के सारे फंक्शंस ट्रेन्स जस्ट पास में मिड दिन एक एरिया डाल दिया, ब्लू में मैं यहाँ इफेक्ट कर पा रहा हूँ मेंटल थिंकिंग अगेन वन ऑफ द मोस्ट प्रिमिटिव पार्ट्स। क्यों क्या नेचर में ऐसा, क्योंकि नेचर ने ये कुछ एग्जांपल्स देखिए हाउ इंटरेस्टिंग इट इज। Through epic journey, species make in search of food or breeding grounds. Can you believe? 12,744 miles. ये टर्टल एक डिस्टेंस कवर करती है अपने फूड के लिए या ब्रीडिंग। एक बटरफ्लाई 9,300 माइल 9,300 माइल्स यही तो रुकते हैं। एक बटरफ्लाई 9,300 माइल ट्रैवल कर सकती है, एक टर्टल 12,744 माइल ट्रैवल करता है। अब आप सोचें कि अगर कुछ ऐसा ही दिमाग में चल रहा है, एक अल्कोहल की तलाश में, एक ओपियोइड की तलाश में, एक कैनबिस की तलाश में, एक वीडियो गेम की तलाश में, एक दिमाग किस हद तक जा सकता है। मेकिंग सेंस। ये कोशिश है ये समझाने के पीछे क्या। जस्ट गिव एन एग्जांपल, जस्ट गिव एन एग्जांपल फ्रॉम माय प्रैक्टिकल एक्सपीरियंस। सॉरी, बिफोर मूविंग एनी फर्दर आई एम जस्ट थोड़ा रूबरू हूँ। So I'll just give you an example. एक मरीज हमारे पास भर्ती थे और वो एडमिट होने से पहले गैस्ट्रोएंटरोलॉजी डिपार्टमेंट में he has vomited blood in the morning. कॉम्प्लिकेशन है, आगे पढ़ेंगे हम जानेंगे कॉम्प्लिकेशन है। तो उनकी उल्टी क्यों हुई, सुबह में एडमिट हुए, दोपहर में जाके how surprising is it? Is it surprising? For me it's not. Why it's not? ये एक टर्टल है, ये किसी साइड से एक टर्टल 12,744 माइल जा रहा है, एक बटरफ्लाई 9,300 माइल जा रहा है। तो हमारे जो मरीज थे वो क्यों नहीं फिर खून उल्टी करने के बाद फिर अल्कोहल पी के चले गए, नहीं चिंता की। क्यों? क्योंकि नेचर ने इवोल्यूशन के प्रोसेस में सर्वाइवल को प्लेजर से जोड़ा ताकि सर्वाइवलिटी बने। So once the brain, which we'll see in few coming slides, once the brain neuroplasticity pleasure के तार जब strong हो जाते हैं, your drug is not for seeking pleasures, your drug is akin to survival. This strong is the relationship. I hope I'm making sense. I'm just repeating it. Survival था, pleasure सब ठीक है, pleasure के लिए सब ठीक है। न्यूरोप्लास्टिसिटी का प्रोसेस आया, प्लेजर से अब ड्रग और सर्वाइवल की बात चल रही है। अब बात चल रही है उस टर्टल की बात चल रही है, अब बात चल रही है उस बटरफ्लाई की बात चल रही है, अब बात चल रही है उस शेर की बात चल रही है जो 200 किलोमीटर दौड़ सकता है, अब बात चल रही है एफर्ट की बात चल रही है। What extent you can go, it's unbelievable, it's unlimited, because survival, pleasure is secondary now, it has become more. The brain is working as if the drug is as important as the person. आगे बढ़े। Evolution unfortunately was still on, और तो क्या हो रहा था, लिम्बिक सिस्टम आ रहा, तो यहाँ तक सब कुछ ठीक चल रहा, पीछे चल रहा, जंगल राज प्लेजर था, प्लेजर के लिए प्रेशर था, प्रेशर की क्वाइट लाइक 11 महीने के बच्चे की उनकी बहुत मुश्किल नहीं थी, 11 महीने के बच्चे की मुश्किल नहीं थी, जब
हाँ।
लगी कोई मुश्किल नहीं। The mind of the primitive brain which inhibit the brakes on prefrontal lobe develop हो रहा था, prefrontal lobe आपको कंट्रोल देना था, आपके बिहेवियर ऑफ सोशल जजमेंट कई तरीके से assess किया। Now what was happening is very important. Nerves, the cells were wired together. In difficult word, this is what is known as neuroplasticity. तो जब हम रेगुलर यूज ऑफ ड्रग we gain कोई प्लेजर सीकिंग बिहेवियर, इसके हम रेगुलरिटी में जा रहे हैं, what we are doing, we are strengthening the wire because nerve cells which are firing together, they are strongly and strongly firing, making it irreversible. Too difficult to बात नहीं कर सकते, तो बात लेकिन जो एक्सट्रीम ऑफ बिहेवियर हम देख रहे हैं वो कहीं ना कहीं ये हिंट आउट करता है कि this को बात so nerve cells that fire together neuroplasticity नतीजा क्या हो रहा है, नतीजा जो प्रीफ्रंटल कॉर्टेक्स का जो कंट्रोल था हमारे प्लेजर से जो एक्सपेक्टेड जो 11 महीने के बच्चे में नहीं एक्सपेक्टेड क्या है, प्लेजर की डिमांड हुई 11 महीने के बच्चे ने प्रीफ्रंटल कॉर्टेक्स नहीं है, इसकी डिमांड कुछ नहीं, लेकिन हमने क्या होना, हमने ये मेरे सेंटर की डिमांड है प्रीफ्रंटल कॉर्टेक्स का कंट्रोल। अब हमने इसको हाइपर स्टिमुलेट कर रखा है थैंक्स टू माय रेगुलर यूज, थैंक्स टू द हाइपर डोपामिन स्टेट। सो व्हाट इज हैपनिंग, द ब्रेन इज नो मोर कंट्रोल ऑफ माय प्रीफ्रंटल कॉर्टेक्स, सो द बैलेंस ऑफ प्रीफ्रंटल कंट्रोल ओवर द रिवॉर्ड सिस्टम इज गेनिंग। नतीजा this imbalance is making it impossible to avoid doing the behavior that is now become both impulsive and is the point of view. Is this addiction? Again, as I told you, I promised you questions. So again, questions: is this imbalance addiction? No, this is not. This modern adopts of medical movement suggests that addiction is गड़बड़ हुआ हमें नहीं पता है, वो बैलेंस क्यों गड़बड़ हुआ, क्यों इन टर्म्स ऑफ डोजेस हमें नहीं पता है, कितने घंटे के वीडियो गेम के बाद हम एडिक्ट हो गए हमें नहीं पता है, कितने लीटर अल्कोहल के बाद हमें नहीं पता है, कितने ग्राम कैनबिस के बाद हमें नहीं पता है, कितने इंजेक्शन मॉर्फिन के बाद हमें नहीं पता है। कोकेन में देखा गया है 1 या 2 एक्सपोजर के बाद ही हो जाता है। So addiction does not exist on a continuum, it is either present or the disease of addiction is irreversible. It cannot be cured and can only be treated by lifelong abstinence. So that's why the importance on prevention, that's why the importance on maintaining recovery. Recovery is a process which we'll see later. So people with addiction cannot control their intake of a given substance. Once they consume any amount, they are powerless to stop themselves from having any more. This is something which I learned gradually over the period of time in the last few years. Alcoholic Anonymous is based on disease. They tell, take a day at a time, you are powerless. There's nothing like control. There's nothing like control. So Alcoholic Anonymous is based on the disease model. So even if sugar is good, a person with diabetes can't have it. ये Alcoholic Anonymous में शायद नहीं लिखा था, ये मैंने कुछ एक समझाने के लिए बात होती है कि ठीक है, मुझे नहीं पता दारू अच्छी चीज है, मुझे नहीं पता रसगुल्ला अच्छी चीज है, डिबेट होने दीजिए रसगुल्ला अच्छी चीज है कि बुरी चीज है। अगर आप डायबिटिक है तो रसगुल्ला आपके लिए डायबिटिक आदमी के लिए खराब चीज है, चीनी डायबिटिक आदमी के लिए खराब चीज है, खत्म। डिबेट ही कहाँ है कि रसगुल्ला अच्छी चीज है बुरी चीज है। शर्मा जी, वर्मा जी, गुप्ता जी सब लोग पी सकते हैं, रसगुल्ला खा सकते हैं, मैं क्यों नहीं खा सकता, क्योंकि आपको डायबिटीज है। So once you have developed a disease, your lifestyle will change, your course of life will change. Alcoholic Anonymous puts it as having developed allergy. They use the word allergy. कि आपका allergy हो गई है alcohol से. Now you cannot continue taking it the way you were taking it. Even if one intake will bring you back to the same state. Now, taking it further, I know I'm making it more gloomy than what it was expected, but this is how the facts are. Addiction in adolescence. Steeper the slope, more slippery the slope. यहाँ पे वैसे मैं एक थोड़ा सा correction कर दूँ. The name of the webinar comes from the country is contribution of Rucha rather than me. So she only suggested me this topic, which I get very readily. So adolescence is a remarkably vulnerable time characterized by changes in physiology, cognition, environmental influence, and social life. So everything is, like, you can say, unstable state. Now, where is the biological process? Why it's made more difficult? We have already discussed it's already a difficult challenge, and now for why this age group is more vulnerable. Now we talked about the balance between the reward process and prefrontal control. So they have a more developed reward process, which is very strongly supported by the peer influence. Now try to understand. Reward process बहुत strong. जो दोस्त लोग और उसको पंप करके ऊपर चढ़ाने के लिए तैयार हैं. एक developed reward process जल्दी तैयार हो. इसलिए भी क्योंकि हमने देखा evolution में वो पहले आया, इसलिए आसान है समझना कि क्यों पहले तैयार हो. So reward process तैयार हो चुका है. प्रीफ्रंटल कंट्रोल धीरे धीरे भी बढ़ रहा है. 11 महीने के बच्चे में एकदम नहीं था, 4-5 महीने के बच्चे में होना शुरू हुआ. एडोलेसेंस में अभी चल रहा है प्रोसेस, ट्यूनिंग का प्रोसेस चल रहा है. So you have a developed reward process, you have weaker prefrontal control, and because of the hormonal influence and some neurotransmitter which is yet to take care of you, you are more susceptible to stress. बात यही खत्म नहीं हो रही है. The physiology is such that you are hyposensitive to acute negative consequences. Try to understand this. मैंने अगर strong at the age of 45 I'm trying some drugs, I'll have strong negative consequences, which is known as bad trip. बच्चों में young बच्चों में bad trips कम होते हैं. So they are hyposensitive to acute negative consequence, but at the same time they are hypersensitive to neurodegenerative and cognitive. So this whole circle, we can see how difficult it makes for an adolescent to get. Now some numbers, thanks to my chairperson who told me to include this. So inhalants, this is an Indian number. 2019, for the first time in India, we had this survey. So for inhalant,
We can't see your PPT. Can I interrupt? PPT is not visible actually.
Just give me.
Yeah.
Not visible yet?
No, not visible.
Just. I'm trying it again. Is it back?
Yeah. Yes, it's there.
I don't know what happened, but sorry for the technical snag.
It's
So
fine.
going forward, the inhalants, for every 2 adult users, there are 3 adults. For opioids, for 2 adult users, there is 1 adult. Cannabis, 4 to 1. Alcohol, fortunately, slightly lesser, but going by the number, it again humongous, 15 to 1. So this is an alarming number, no doubt, and it's a very recent. Now, I have brought only and only questions till this time. So now what I will request my colleagues. So, am I visible now?
Yes. Yes, sir.
Yes. So now, with all these questions, I'll take a break. I'll request Rucha and Gaurav to take it forward. And at the end, I'll just sum up few questions again. As I told you, I'm full of questions. I'll again put few questions, which we'll seek for answers in our coming decades of practice program. So over to Rucha. Rucha, please continue.
Thank you, Dr. Vijay. Your presentation was very impressive. It was very easy. Easy. People are very easy to understand whatever you have talked today. I hope the students were able to understand the concept of addictions and all. Thank you very much. As you said, now I request Ms. Rucha to deliver her talk. Rucha, please. You're most welcome.
Hello. Thank you, sir. So, moving on. Vishwas, can I have my slides, please?
Yes, ma'am.
Hello.
Yes, ma'am. Wait.
Sir has talked about a lot of heavy stuff, which is neurodevelopmental, बड़े शब्द थे, sir. So, I will try and keep it as simple as possible. And I am not going to talk about opioid, अलग से, alcohol, अलग से, internet behavior, internet addiction, अलग से. I'm just going to use the word addiction. The intervention strategies are mostly quite similar across all addictions. They definitely have to be tweaked a bit, but the basic principles remain pretty much the same. Okay? So can we have the first slide? Yes, from the whole neurodevelopmental thing, we go on to the first one. इसके पीछे वाला? Yes. Just a small summary of what the presentation is going to contain. I would like to elaborate on the concept of psychosocial risk. Also talk about what the addictions mean for the client. Going on to the web of causation, associated factors, some psychotherapeutic modalities, and just touching a bit upon the pitfalls in therapy. Okay, next one. So moving on to the concept of psychosocial risk. What is psychosocial risk? Psychosocial risk has to encompass all potential outcomes and consequences, and not just the biomedical. The reformulation of risk includes the positive, desirable, and sought after consequences too, apart from the negative and adverse outcomes. For example, smoking marijuana can lead to social acceptance by peers, which is likely to be a sought after consequence by adolescents. Next one. Next slide.
Yes, ma'am.
So why doesn't just say no work? After all, everybody knows that the long-term adverse effects of addiction are very clear. The reason is likely to be that the addictive behavior serves important social, psychological, personal functions. Therefore, they are unlikely to be abandoned in the absence of alternatives that will provide similar satisfaction. Next one. I would like to deliberate a little on the function on the इसके पीछे वाला.
This one, ma'am.
Slide number 5.
Wait. This one.
Yes. So I would like to talk a little about the latent driving factors. What other purpose does the risky behavior serve for the adolescent? It could be something like peer acceptance and respect, establishing autonomy from parents, repudiating established norms, values of conventional authority, coping with anxiety, frustration, or an anticipation of failure, coping with negative affective state, affirming maturity, and making a transition out of childhood towards a more adult status. Research tells us that indulging in risk behaviors serves many functions for the client. If these are not addressed in treatment, the changes are likely to be ill-sustained. Next one. Adolescent is marked, as Sir has already told us about, the reward hypothesis, which is very strongly established. So the
two main processes over here is the frontalization and the dual system model. There is a asynchrony in the developmental trajectories of these two neurobiological systems. It results in a stronger bottom-up reward-related drive and an inadequate regulatory activity, which leads to impulsive risk behavior. And this is especially so in adolescence. Moving forward, I would like to elucidate a bit on the associated factors: emotional dysregulation, alexithymia, and sensation seeking. Next one. Let's first look at what is emotional regulation. Next slide, please. Yeah. So it is a multi-dimensional construct encompassing different abilities and processes. What is the goal? The goal is to maintain, modify the current or expected affective state with respect to its intensity, quality, and duration. Includes intentional as well as unintentional components. Undergoes specific developmental age-related changes from childhood to adulthood. Also, emotional stability is quite low in adolescence. Next one. Thus, we can say that emotional dysregulation is a hallmark of addictive behavior. Next slide, please. Poor emotional regulation abilities predispose the previous one. Poor emotional regulation abilities predispose the person to addictive behaviors. Research suggests that adolescents use drugs to end the aversive emotional states and increase the positive effects. Let's talk about alexithymia. Alexithymia has emotional and cognitive components. It is defined as a difficulty in identifying and describing feelings, differentiating in bodily sensations, feelings, lack of fantasy, and externally oriented cognition. It can be divided into two primary styles. Primary alexithymia, which is likely to be a personality trait arising out of early genetic vulnerability, and secondary or organic alexithymia, which is a cognitive deficit arising out of a mental illness or a brain injury. Research tells us that alexithymia is very common in adolescents with addiction. Addiction, but we do know that it does play a role for sure. Moving on to sensation seeking. Sensation seeking is defined as a personality trait strictly connected to the vulnerability of adolescents towards reward-related behaviors. The dual system model lends the adolescent behavior a highly effective tool, because adolescents are known to take social, physical, legal, financial risks for novel, complex, intense experiences and sensations. Let us now look into the concept of risk behavior syndrome. It has been seen that deviant behaviors cluster together. Next slide, please. It is easier both for the understanding as well as intervention to deal with a cluster of behaviors together than with the individual behaviors. The reason why they cluster together could be that the different risk behaviors serve the same psychological functions. For example, illicit drug use and precocious sexual activity may be a means of affirming independence from parents. In a longitudinal study of high school youth, about 61% of marijuana users were also sexually experienced as compared to only 18% of non-users. We now move on to the web of causation. The web of causation has a few factors such as biological factors, social environment, perceived environment, personality, and behavior. I'm going to talk only about the personality and behavior aspect of the web of causation. All the factors are dynamic, interlinked, as well as bidirectional, and are known to have direct as well as indirect effects. The apparent complexity of the issue bring to light why single domain interventions are are likely to fail. Thus, the social environment risk factor of poverty, let's say, apart from the direct effect that it will have on the client, it will also have an indirect effect in the domain of personality by affecting the individual's perception of perceived life chances negatively and thereby indirectly influencing his risk behavior. Next one. Let us look at the personality and behavior component a little more closely. Early problem behaviors such as difficult temperament, frequent negative mood states, withdrawal, irritability, social alienation are frequently reported by drug abusers. Also, there is seen a low level of commitment for education, paucity of executive functions, and an inability to delay gratification. It is seen that decreased drug usage correlates inversely with plans for higher education. If they see a better chance for themselves in future, they are less likely to uh, to get into the drug use. I'm going to touch upon this very briefly. Psychological assessment. It would be basically to get a clarity of the diagnosis, whether we have a dual diagnosis, we do not have a to rule out or to establish a dual diagnosis. It does give us a better grasp of the patient's personality and it can aid in planning therapy. Many scales and questionnaires are used to assess the patient's use of substance, intensity, willingness to change. There are many scales which do that. Almost all addictive behaviors have scales, questionnaires specific to them. Although there are a plethora of therapeutic modalities available, I'm going to talk about just a few of them over here in detail. It will not be possible to go on about all of them. Also, if we understand the basic principle, I think there is a line which runs through all of them, a common line which runs through all of them. Okay. Next one. As Sir has also already mentioned about the Alcoholics Anonymous and the 12 steps program that they run. The 12 steps program is a set of 12 affirmations which the Alcoholics Anonymous have. It was founded by Bill Wilson and his physician Bob Smith. And the 12 steps program has been adapted for almost all addictive behaviors, substance as well as behavior. Moving on to relapse prevention. Relapse is defined as a setback that occurs during a behavior change process, such that progress towards the initiation or maintenance toward a behavioral goal is interrupted by a reversion to the target behavior. It is conceptualized as a dynamic, ongoing process and looked at as a learning opportunity. A lapse is seen as a fork in the road which may lead to a relapse or a prolapse. Now, what is a prolapse? When the problem behavior is corrected and the desired behavior reinstated post a lapse, it is referred to as a prolapse. Lapses are considered as temporary setbacks that present opportunities for further learning. Moving on. Some of the key components of relapse prevention are high risk situation. Now, what is a high risk situation? High risk situations could be emotional or cognitive state, such as negative affect, or a diminished self efficacy, or some environmental contingencies, such as flu, or a physiological state, such as acute withdrawal. Whether a high risk situation culminates in a lapse depends entirely on the coping response that the individual employs. Cognitive factors and outcome expectancies have a huge role in determining relapse prevention and relapse liability. Peer approval, or say a fake sense of adulthood, are some of the outcome expectancies which we need to deal with. Another concept is that of abstinence violation effect. It is a dichotomous view of a relapse, which does not take situational explanations for the lapse into consideration. If a client views a lapse as a personal failure rather than a result of a combination of factors, he is likely to feel very guilty and may permanently abandon the behavior change goal. That I will never be able to do it. So just forget about it. Next one. Relapse prevention takes a two-pronged approach. It talks about specific interventions and it talks about global interventions. In specific interventions, the client is told to anticipate and have a relapse management plan ready. If the client is aware of his high risk situations and better prepared for them, he will better manage the lapse. The appraisal of the lapse, accurate appraisal of the lapse also helps. Cognitive restructuring is needed to reframe the meaning of the lapse and minimize the AVE. On the other hand, global interventions focus on lifestyle balance, engaging in rewarding and stress reducing activities in their daily routines is encouraged. Success in these areas enhances self efficacy, thereby reducing relapses. Next, so let's move on to cognitive behavior therapy. I would like to spend a little bit of time on the tenets of cognitive behavior therapy as regards addiction behavior. Okay, so what over here? What does modeling mean? Modeling is how the parents, peers model the addictive behavior. Operant conditioning will pertain to the exposure to addiction resulting in pleasure. So the behavior is reinforced by its consequences. In classical conditioning, we are seeing the exposure to high-risk situations which are associated gives rise to craving. Functional analysis is also employed as regards managing addiction. There is a there is a there's a skill set which is very which needs to be taught to the client. In that, we look at refusal skills, enhancing social support, and coping with relapse. Okay? So, refusal skills. Now, what are refusal skills? Refusal skills is the ability of the client to say no to the substance or to the behavior. What is taught to the client? The client is taught the verbal and non-verbal components, such as they are told that no should be the first thing that the client needs to say about maintaining eye contact. So all these small little intricacies of how effectively you can refuse when the opportunity arises is taught to the client. Role plays can be employed. The client and the therapist can briefly review the situation. Uh, the whole process is explained to the client. They both can decide on which role is played by who and then practice it. Second is enhancing social support. It has been found that clients with addictions do not have as much social support as they would like, or their social support has shrunk to people with similar issues, so that is of no help especially when they want to be on a path to recovery. Client can be helped to recognize and form his own social support by asking a few questions, such as who might be able to support you, or who has supported you in the past. Potential sources can be family, friends, teachers, acquaintances, professionals. What type of support will be helpful for the client? Is it help with problem solving, moral support, or information regarding something, or financial support? Also, the client needs to be educated as to how to get the support that the client needs. And the simple thing to do is ask. Be direct and be specific. Next, let's see how to cope with relapse. Coping with relapse, it is one should take a very positive approach to it, thinking that relapse is bound to happen and it's not a failure, it's just a setback on the road to recovery. It is considered normal and expected. The emphasis is on being prepared for relapse. That increases the likelihood of effective coping. Forearmed is forewarned is forearmed. Identify the high risk situations. Relapse is likely to be accompanied by guilt or shame, and that needs cognitive restructuring. Lapses have to be looked at as learning experiences and not as a full and finality of the process. Next one. So we have a problem-solving model of approach, problem-solving model to coping. It is based on 5 questions. First is there a problem? What is the problem? What can I do about it? What will happen if? And finally, how did it work? So the first and foremost important thing is to recognize a problem. Identifying it as accurately as possible, taking into consideration all the components such as the social, environmental, biological, personality factors, everything, as many components as we can. Identifying it as accurately as possible is better. The client should generate as many solutions as possible and then choose from those generated solutions. He can either change the situation or reframe the situation cognitively and select the most promising action as regards the situation. Once the action is employed, the client should review the action, examine the efficacy of the approach. Did it work? Are there any amendments needed? Can it be changed for better? Are there any pitfalls that we did not see coming? Moving on to motivational interviewing or motivational enhancement therapy. Motivational enhancement therapy is based on the premise that clients will be able to achieve changes when the motivation comes from within than from without. The basic tenets of MI and MET are quite similar. MET combines the clinical style of MI with the individual assessment feedback that is particularly helpful for less ready clients. Okay, can we look at the key concepts in MET? Next one. Next slide, please.
Yes, ma'am. Yes, ma'am.
The first is ambivalence. MET recognizes that it is normal to have mixed feelings about change and that giving up a target behavior can be quite anxiety provoking. The therapist's task is to have an open and non-judgmental discussion about it so as to influence the client to change. Moving on to reflective listening. Reflective listening pertains to the statements made by the therapist that express his or her understanding of what the client is saying. There are a few types of it. Simple reflection, wherein it is just rephrasing what the client says, or reflection of meaning, wherein the therapist brings out what the client means. Reflection of feeling, bringing out the feeling that is implied in the statement. And double-sided reflection. Reflections acknowledging what the client's ambivalence about the need to change. An accurate reflection is crucial to facilitating change. MI employs a lot of open-ended questioning as against close-ended questioning. Open-ended questions elicit a very elaborate response from the client, which can help us move forward. Key strategies that have to be employed. Expressing empathy and acceptance. It is important to listen and communicate respect to the client than to tell the client something. The aim is not to convince the client the error of their ways. That is not the aim. Second is developing discrepancy. The therapist has to underline the discrepancy between what they are and what they want to be. Reflection can be used to bring about the client's own stated concern of how predictive behavior interferes with goal attainment. Avoid argumentation. At no point is arguing with the client a part of this therapy. It is to be avoided at all costs. What happens is it just generates resistance. The trick to avoiding argumentation is to treat ambivalence as a normal phenomenon and explore it with double-sided reflection. The client's resistance in MET is more sometimes to do with the therapist's judgmental attitude, rolling the resistance. Do not confront the client's resistance. One has to empathetically reflect the client's hesitancy to change by letting him know that it is up to him to decide when and how the change will be effective. Supporting self-efficacy. Helping the client develop a belief that he or she can change is very important. Clients with serious issues are unlikely to move towards change unless there is a hope for success. The therapist can extrapolate earlier successful changes to this situation to give the client a belief, a faith that he can do. Next slide, please. Across the approaches, a few things that we are seeing is that most of them have a very a very a very they have a very positive approach to relapse. They look at relapse as a learning opportunity rather than as a failure. Identifying high-risk situations is common to all. Preparing to handle them beforehand. And where we are taking away a few behaviors from the client, we have to supplement it by giving the client an opportunity to engage in positive behavior, which is affected by lifestyle balance. Some pitfalls in therapy. The client may threaten to harm oneself. They are late, sometimes completely miss sessions. They may even turn up intoxicated for the therapy. So these things happen and they will have to be dealt with as and when. Thank you.
सर उसको पिन करना होता है
Gaurav from now take us further to the psychosocial science and the article.
Thank you, Ms. Rucha. Definitely, it was very quite impressive presentation from your side. I hope the students will be benefiting by your presentation. Thank you very much. Now I request Mr. Gaurav to do his presentation. Mr. Gaurav, Giri. Gaurav, are you there?
Because please check the PPT. It's not coming. Full screen is not coming. I think there was some issues.
ओके मैम
Please check that.
Your full board presentation. Presentation mode for us.
Gaurav sir, you are not audible.
Vikas, tell Gaurav. I think he's mute. Tell him to unmute.
Yes, sir.
You can do your presentation.
Yes, sir. I'm going to the presentation. Basically, we have to discuss here the psychosocial issues, especially the family and
Your PPT is visible?
yes, sir.
No sir.
It's not visible, I guess.
It's not visible.
Yeah.
Which one, sir? The 50 is visible?
No, sir.
No, sir. Check.
Can I share, sir?
See.
Okay. Yeah. Now it is visible, sir. Okay.
In the presentation mode.
Yeah. So thank you, sir. So basically, we have to discuss here the addiction in adolescent age sleeping. So basically, we have to focus on the psychosocial issue on the basis of the map on the discuss the psychological, visceral. We have to discuss the biological. The major thing in the as an adolescent, the very effective society and yeah, as family. So, because basically, uh, the presentation is the outline, the modeling of biological theory of addiction in adolescence, risk factor, relevant family-based theory, and the psychosocial intervention, limitation of some psychosocial intervention. Is there. So, please change the because. Start with the introduction. Adolescence is a very critical developmental period that involves puberty and maturation, continued brain development, and the change in social life. And the risk and the increased risk of behaviors such as substance use and other behavioral problems. Why is it called the critical developmental period? Because of the certain thing changes in adolescence period, like physical and psychological. The child turned to the adult and the period with the rapidly psychological and physiological changes. The demand for new things like social social role to take the place. And if the mainstream erosion do not be changed like proper way, like face like crisis like dilemma for the road, and sometimes the child adolescence made a significant difficult to adjustment in the environment because of role change and biological changes. Next. We will not be going to the discussion the according the criteria DSM 4 and DSM 5. But basic things are covering addiction in DSM 4 refer to the compulsive like pathological gambling and alcohol. But in DSM 5, this criteria are substance related and the addiction addictive behavior. Okay, because so major uh, part of the things is the like theoretical background. Is what is the etiological theory of addiction in adolescence? So the social developmental model is a general theory of human behavior that hypothesizes a similar development process leading to either the pro-social or anti-social outcome, especially for some model for a specific period of childhood and adolescence. So overview of the theory is the like social developmental model in a growing body acknowledge regarding the effect of empirical risk factor. Next slide. Basically, what is the risk factor? So today I will focus on the social cultural factor, especially the social cultural factor. Social contribute the increased risk in the adolescent addiction, which is the influence deviant peer relationship, popularity, bullying, and associated with gang, social and family influence are the often present simultaneously. So next slide. Please. First one is the deviance peer relation. The influence of peers on adolescence and addiction often exists in the form of the deviant peer relationship, wherein the adolescent associated with the group of people who are the addicted. Next one, the peer pressure and popularity. The similar peer pressure and popularity, pressure and the perceived popularity have been shown to associate with the increased risk of adolescent substance use related problem. And another is the bullying. Bullying is bullying as a serious interaction whereby the group of individuals use the verbal or physical assault. So study indicate that the victimization is the possibility with the other common substance use, including marijuana, inhalant, and other drugs use. Another social cultural factor, gang affiliation. A legal definition of gang is the group of the three or more people that is characterized by the criminal behavior. A significant positive association between gang affiliation and the substance use, which has been shown to exceed the influence of typical deviant peers group. For example, we have seen the in the railway station a very young child who use of legs, drugs, and we are getting affiliated with others group child related to problem. So relevant family-based theory of addiction in adolescence. These are the theory based. We have to focus on four major theory: family system theory, social cognitive learning theory, social control, and family risk. Sorry, risk focus theory. Next slide. First one, family system is characterized by the structure and the behavior. Structure and behavior like family as involved in the expectation structure of the family, and the structure of family is a multi-dimensional system composed by the interrelated functioning like parent, child, and other family members. These systems interact with each other. The element of the family structure are the boundary. If the boundary are rectangular, in the boundary are each subsystem has the role followed, the role must be clear to define in the other promoted family function. If the role is not defined, they are most often seen family are very deviant and very pathological family. Second is the social community theory. It's the base on this provides the social behavior acquired through the direct conditioning by the imitate modeling of other behavior. The influence of external factors such as the parental influence is stressed in the theory. Basically, we have to focus on the internal factor in the social cognitive theory. If you first one, attention paid to the role model is a family member, sustain the attention, panic to the model behavior, motivate to the behave according to the model behavior, exhibition of model behavior. So we have to show that a picture. There are certain things are child or formation behavior to learn from the family. Next slide. Second, next is social control theory. Social control is control the construct of attachment, commitment, involvement, and belief. The theory based on the theory, adolescents with higher level of attachment, commitment, involvement, and belief are less risk for deviance. So, for example, the family, very big boundary of the family, like the deviant family. So, there are commonly found that such family adolescents very early age start of the substance related problem. So addiction problem is assumed to be the result of the deep bond of the family, school, and family system. Bond these systems related directly to the level of substance use. Next. And the last, the risk focus theory is basically the cognitive learning theory and the control theory. We are mixing. The risk factor are associated with the social developmental model emphasize the on the building factor and reducing high risk. The risk focus model identify the various sources of risks and the prediction for the substance use including family, peers, school, and the community system. Next. So we have to discuss with what is the risk factor in the family. Many risks and the productive factor influence in the age of onset and the severity of addiction among the adolescent. Family risks factor including the childhood, maltreatment, abuse, neglected, uh, parental, family substance abuse, marital status of parents, and level of parental education, parent-child relation, family economic family economic status, and the child perception of the parent through the substance use. So there is two factors: risk factor and the protective factor. Uh, there's some certain things in the family: parental monitoring, chaotic home environment, parent modeling of substance, codependence, parental overprotection, quality of communication with parent, unrealistic high expectations. So these are the things in the family. They are the risks to problem related to those. Next. So what is the effect in the family? Basically, if your family are very chaotic, so what is the effect? Basically, emotional burden. So member feel very anger, frustration, anxiety, fear, worry, and same guilt. And next one, economical burden. Economical burden because the money spent on substance, many problems associated with loss of job. So these are the problems. Relation with dissatisfaction, family member experience a high rate of the tension, conflict related to each other. So these are the problems in the family. And the last is the family instability. Instability means the violence, family breakup, suppression, divorce, uh, removal of adolescents from the home. So these are effects on the family and feel the family member. Next. So what is the productive factor? Productive factor are based on the some model. First one is the social developmental model. Social developmental model emphasizes the role of bonding in family and school, religion, place, and the peers. If the bonding each other, the family member, their family are very productive and that may be decrease the behavioral problem. Next one. So, first one is the structure. So the early stressful life event and the negative parental interaction to lead the childhood inhabitant control and then lead to the childhood deviation and later on the develop the substance and behavioral problem. So uh, the stress model approach emphasize the model to help the better understanding and better understanding vulnerable to risk behavior by the looking for at the risk factor that can increase. So certain things are component we have to discuss. First one is stress, normalization, experience of substance use, attachment, and skill and resource. Stress means basically major life event, enduring life stress, normalizing of subject, legality and law enforcement availability, sponsorship, emotion, media, presentation, and cultural group. Third one is the experience of substance use. The depend on the user, how is the game substance are setting and how you the dependence follow the rule, broken the rule. Attachment, positive attachment is the personal connect to the people, and basically negative attachment are connected to people are very offensive behavior, yeah, deviance behavior. And the skill and physical performance and capability. If the individual, yeah, say into the internal behavior problem, yeah, social ability to person to manage the thing. If not be able to think properly, we have some frustration develop in later, especially in adults in education. The parental pressure for high expectation from education, marks, and everything. So the adults are more feel very negative things, take very negative things, and then we have not to perform it properly. And the last one is the resource. Resource is internal things willing to work hard environmental resources such as food, money, and food. These are the things are modify the stress level. Next one. Problem solving model, which is the emphasize that adolescent behavior including mix and protective behavior and protective complex interaction between people and is their involved. There, see the picture. The people are able to solve the problem. So he has some positive interaction with others. If it is difficult to the stressful life in the individual, so it will be difficult to interaction with the environment and family and also. So the protective factor the mitigate substance use among the adults, including the stable family life, stranger parents, child relation, and academic. Physical and sexual abuse. When the victim of physical and sexual assault, increased risk of the adults getting the violence with the substance use from 2 year 4 time. Different studies have shown the very specific result regarding the which type of abuse with the adults in contribute with some report high risk of associated with the sexual abuse, but other report a higher risk associated with physical abuse. Next one. Peer factor. During adolescence, the influence of parents is the subsequent by the time of peer group. During the period involved the first experiment with the less socially disapproved substances like the alcohol and the tobacco as the gateway drugs. People who have wished to use alcohol often drawn the towards peer group. With a similar gateway drug. People who wish to often use drawn the towards the peer group, the similar motivated and drugs taking attitude. Next. Social media. In terms of social media, refer to some various internet-based network that people are unable to use and interact with other like verbally and non-verbally. If you talk about the adolescent, the period of person and the social identity formation, you must have the development of new reliant on social media. Because they have the limited capacity for the self-regulation and their vulnerability to peer pressure. It will be difficult to show the slide. Because
Yes, sir.
it will be difficult to slide in the last half. Social, some theory. We have to discuss about the social comparison theory. The people tend to compare themselves to others, assess their the opinion and ability. The comparison are the upward comparison are downward. The self-improvement motivate keep the self-improvement. The downward is the like self-esteem and avoiding failure. Next one. Next one is the stressful liability. The current outbreak of novel coronavirus disease in the spread of Wuhan, it become the pandemic affect every country. The COVID-19 breakout the result of the death of the nearly so many people. So the COVID-19 outbreak and the lockdown may have the multiple effect on the living of the adolescent, like panic and acute distress, very for their family, unexpected loss, sudden school break, and home hello, because
Yes, sir.
not people is like that.
Sir, please pin my presentation. Sir, bold time.
Gaurav is visible.
Okay, sorry. So COVID-19 pandemic having a psychological impact on individual uh, life.
Gaurav, can you skip some slides or just as you try to conclude your whatever presentation you're doing? Because we are lacking time.
Okay. So there are some, we have to go into the psychosocial management, basically adolescent community-based reinforcement, family therapy, multidimensional family therapy, next, multidimensional family therapy integrated approach which making the family therapy into individual and the multi-system family therapy is a approach to alter multiple risk factors that create the maintain the adolescent drugs abuse and behavior problem. So these are the peer, school, and community. Ecological based family therapy based on the usage and the family functioning as well as system and impact on the adults. Next, functional family therapy based on family therapy focus on behavior based aim to alter the maladaptive family pattern, maintaining the adolescent problem. The main treatment of main treatment aim to change the negative family interaction use to behavioral intervention to enforce the positive to respond the more effective problem solving approach within the family. Next, brief family intervention treatment designed to work with families during the substance use inpatient detoxification in order to the participate in aftercare. Basically, inpatient families to involve the intervention. Intervention is delivered in the one session either on the inpatient by the phone conference and include the drugs used and the family member living with the patient. Next, structured family therapy. Structure the very importance basically we have seen in the family where deviance role performance in the family. So structure family therapy pattern diagnosis based restructuring to alter the family interaction. To keep the youth and family engaged the treatment to making a significant change in their life. Next, therapy is a social resistance skill. The skill training program teach the adolescents how to recognize situation where they are likely to experience like negativity, the peer pressure, like peer pressure for smoking, drinking, and other drugs. The three components of drug resistance skill: personal self-management and general social skill training. Next, interpersonal interpersonal. Basically, activity focus on the connection between the current symptom and the interpersonal problem. Next one. Other psychosocial management, parenting counseling, community-based rehabilitation, telemedicine can improve the during psychosocial management. Telemedicine, psychosocial intervention, the few adolescent addict turn for the treatment. Some of the region denial the adolescents having any problem regarding their substance ability. Adolescents care not be wanting to seek treatment, even if they are admitted themselves. They have some problem. General lack of adolescent treatment program like psychosocial management and treatment program not being appropriate and suitable for the adolescent, playing the distortion by adolescent self and occurrence of spontaneous remission, maintaining the adolescent addiction problem, playing the distortion of addiction self and possibility of invalid state instrument for measuring addiction in adults. Next, to conclude the basically risk factor and protective factor. So adolescent substance use become a serious concern nationwide, although there are many ways of making the adolescent substance use, but family influence has been the established one of the strongest source of risk and protective factor. Parental influence seems to be the strongest perspective of the adolescent substance use. Adolescents use uh, substance in order to cope with the parental vigilant hostility, rejection. So these are where the other immediate behavior pattern as they are used to do drugs to cope with their one situation. They may be lead to the stress linked with adolescent substance use. It means the family also be the protection for the adolescent substance use through the positive introduction and the role model. So if the evidence-based family therapy can be very effective to treat the addiction in adults. Next, thank you.
Thank you, Gaurav, very much. I request Dr. Vijay to conclude the presentation.
Thanks a lot. What I will do, I will just run fast through my slides, and I'll just like to focus on one of the last two slides. Okay? Thank you. So let's mention some more. We talked a lot about two things. So what are we trying to do? I just read this question without much of deliberation, just two headings. Withdrawal symptom, addiction versus its complication. We are targeting abstinence, we are targeting recovery, or we are targeting prevention. I will just press the now there is another conflict whether we are targeting treatment or whether we are targeting harm. So for adolescents, prevention strategies at the level of family, school, community, and individuals. Catch them young and watch them grow. For those who are really interested in prevention strategies, because I was seeing some questions, it's a wonderful reference, and again sent by my chairperson. He has asked me to include it, but I thought that why not to include the name of the reference rather than making it more elaborate. It's a wonderful comprehensive coverage into the principle, planning, and delivery at all levels. A wonderful reference to the state of success, and you can read it. It's a book of 60 pages of planning. Wonderful. Adolescents, yes, they present a lot of challenges, and still in rehabilitation, groups of recovery, and extended care is needed for them. In contrast to adults, who are only approving group of recovery. Now, these are the two slides which I was keen to share. Look at the uniqueness of the person, not at the commonality of the time. Formulate the case. Look for the interaction between the agent, the host, and the environment. Already summed up wonderfully last week. Believe me, one of my senior colleagues at rehabilitation center would tell me, अगर तुम फैमिली को मैनिपुलेट नहीं करोगे तो पेशेंट फैमिली को मैनिपुलेट करेगा. Not using the word manipulation, but educate the family. That realistic and common goal. What is the family expecting out of the people? What is the patient expecting out of the people? What is the board expecting out of the people? To this common. That realistic and common goals. Include the sensitivity of client and family. Relax the rule rather than exception. Also was quite elaborate about it. Never feel disheartened as a person. Keep in mind you are just a small cog in the large wheel of the family. Keep working with the family. Educate about sleep and relax. Don't feel medical care. Remember, not about your quality, but your persistence and your nature. Please remember, treatment starts with abstinence. Doesn't end at abstinence. So abstinence is the start of the treatment. With these words, I will keep promising and keep.
So before giving to Bakhla sir, I think we should finish question answer session. Dr. Vijay.
Yeah, not a bad idea, but I think let's include Bakhla sir in the question answer session. So first, let him finish.
Also suggest because there are plenty of questions.
Ask him only.
Okay, okay.
Okay. It will be better if people come with their questions because many are maybe waiting for very long to ask some important question. So I think participants should start, and if time permits, I will conclude.
I request the participant if they want to ask a direct question to the speakers, they can ask, or from the chat box. Also, I can read few questions are there in the chat box. I can also read from the chat box. If the participants are there, please ask question to the speaker.
And if I was thinking to become chaotic, why not to read from the chat box?
Okay. Yeah. Then the first question that is, are the reasons for getting addicted differ as per age of the individual or stage of life? As the adolescent fall in the excellent stage of development, identity, but adult stage is more a stage of intimacy. I think this is for Ms. Rucha. She can reflect on this question. She can say what she thinks about this question. Can I repeat the question?
Ma'am, please unmute yourself.
Yeah. Yeah, am I already audible now? Yes. So I think there are going to be a few differences as regards age and stage of the client. The amount of social acceptance, peer pressure that is there in adolescence, it diminishes as you grow up, as you have your own set of values and things to live about. But there will be other things. Economic failure is not going to probably propel an adolescent towards addiction so much as it might propel a adult. So yes, they would differ, I would say.
Another question was raised, what are the risk and protective factors at family and community level which may lead to relapse in adolescence? I think Gaurav has already presented. I think we should not take this question. Gaurav has beautifully talked about the risks and protective factors. So we won't take this question. The question is how to deal with the intoxicated client in a therapeutic session.
You don't deal that. You don't deal. You do not. The session does not happen. It gets terminated. The session is terminated, mind you.
And then one important question I think raised by one of the participants. Do the model of addiction take consequence of cultural diversity? And is there any model more effective in Indian setting? I think this question goes to Gaurav, I guess. Is there any specific cultural diversity model? See, lots of cultural factors are related with addiction. So, Gaurav can highlight about the cultural factors associated with addiction.
Yes, sir. So cultural factor increase the
There is a specific cultural model to deal with this addiction issue.
so basically the one model is very effectively community-based rehabilitation, a community-based intervention. So in community-based rehabilitation, the individual being integrated, actually included the family with adolescent in the session, in the community base. And this program into the community have like different team to involve with the this treatment plan like PACE, psychiatric, social, and clinical psychology in the community-based treatment. For the patient who are very unable to involve with any treatment plan like inpatient setting. So community-based rehabilitation, we have to focus on this in their community we have some certain things where we have used the utilization like primary labor and
Okay, Gaurav, I think from the audience, from the participant, even can contribute on the cultural model of addiction.
yeah.
Anyone from the participant side? Maji sir, Convener sir, anyone can talk about the cultural aspect of addiction?
Just Arif, one or two addition, not a model. I'm not talking in terms of model. See, culture is very closely related to the way different things are accepted and perceived. So lot of initial behavior around the say for example for alcohol, and different culture, different societies have a lot of acceptance to it. When we in such cultures, in such areas, when we detect the problem, by that time it's already a bit late for them. That is something which is very practical for us to understand that this person is coming from what background. Like a person coming from northeast to you with problem, a person coming from Haryana to you for intervention, their requirement might be the same, but you will see that the stages are very different, so the whole treatment modality is different. That is, I have felt very good practical experience. And
Thank you, Dr. Vijay. Anyone from the participant side? Like
Yeah, am I audible?
Yes, sir. Maji sir, please go ahead, sir.
Yeah, I have not come across anything from cultural perspective of therapy. However, what Dr. Vijay, I think, he already told about the community acceptance. That is very important. Most of the culture they accept that, and especially in tribal community, it is open society, where every household they used to prepare all these things. That way, it is open society, and they need to perform puja with this alcohol and all. That is already present there. But I have never come across specifically how to deal with all this kind of issues. What Gaurav was talking about, in Western countries, they try to deal like associative community treatment model, but that is not exist in our society. And
Anyone? Anyone? Or shall we move to another question? Yeah, the related question was raised by Upender. Is there any model that work with substance abuse among underprivileged children like homeless street children? I think again this question again was for Gaurav, I guess. Is there any specific model which is we can talk a lot about model? The model that deals with the underprivileged children like homeless street children like that. Because lot of cases we see of use of dendrite and all about the street children. Is there any model specific to deal with this kind of issue?
During the presentation, we have focused on the one point, right? Social, social resistance skill basically focus on this training program to teach adolescents how to apply the situation in different person yeah, child who have the different parts of different problem who likely to experience like peer pressure to smoke, drink, and other drugs like behavior. So this model registers
Sorry.
sorry, sorry, to deal with the certain thing about the behavior and how to control, how to stop, and how to know about the problem really substantially.
Then we'll go to next question. It's for Dr. Vijay, I guess. Is there any neurobiological theory about relationship between intelligence and addiction?
yeah, definitely. I'm not saying that any specific theory is there. A lot of observation, a lot of studies are there. When we talk about intelligence, we talk about many protective factors. About risk-taking behavior. The moment intelligence is at compromise, risk-taking behavior, decision-making that is risk-taking behavior, not responsible or decision. If your intelligence is not capable enough to make those decisions, this will be more prone for making such mistakes, errors, and easy for you to get into the trap. Definitely, lower the intelligence, lower all the studies, not very moderate, moderate or severe intellect disability, or borderline, they have a high.
There was one more question. Okay, sir. So you were telling something, Bakhla, sir?
Hello. Basically, I was just wanted to add on Vijay concept. Basically, intelligence may not be very relatively involved in terms of IQ, but the two other types of intelligence, like social intelligence and emotional intelligence, those are more important in relation to addictions. Because how do people control or regulate their emotion or socialization, that is more important in relation. So, intelligence in relation with emotional and social intelligence is more relevant in addiction. Thank you.
Anyone would like, there are one or two questions, can we take or time is?
Yeah, you can take if Vijay and Dr. Bakhla and other, they have no such. You can take.
Yeah, there was one participant who talked about media and the situation of media and addiction during adolescence. So, if any one of the speakers would like to highlight, because they are taken as a role model, media, they are watching songs, they are seeing TVs and all, and they are trying to replicate it. So there is a question whether what is the association with the media and substance use among adolescents.
Yes, sir. I can answer. Sir, the media and the substance related very positive in the during the pandemic situation. Like social media to regard a double edged sword बोलते हैं इसको दो धारी तलवार इसको एक तलवार है जिसका यूज करके we get the informative. Second, we have to very addictive. We not only mobile internet, we have lost the network, we lost the internet. We have some psychological distress. We have some psychological problem. We have always searching certain thing. We have found some research on the internet. I'm talking about the behavior addiction in the media and the related to addiction. So addiction more like why sir? So the greater risk of developing sir behavioral problem in terms of media, social media, and addiction. Because certain person would very evolving like situation in the media in this last year certain time. So you have is a positive and very negative. Very one thing is very informative, one thing is very very problematic in like media, social media.
Thank you, Gaurav. There was one question from the viewers who watched through YouTube. He has asked if a person is taking antidepressants in last 10 years, it will come under addiction or not. I think it's for Dr. Vijay only.
Yeah, as we understand it very clearly, when we talk about concept of addiction, we are talking about compulsive, we are talking about inability to control, we are talking about there are many basic biological concepts we are talking about when we are talking about them, as well as psychological, as well as psychological. So, if I'm taking antidepressant for 10 years, it's not that I started with 5 milligram and I'm ended up at 500 milligram taking it on my own. So I'm not tolerant to it. Second, there is no urge and compulsion to take it. It's not that you antidepressant देने के लिए बीच से बोल के भाग के जाके दुकान पे चौराहे पे जाके दवाई खरीदना, वैसा नहीं करता. So I'm not. There is no compulsive. There is no craving. ऐसा नहीं कि रात के 12 बजे की जल्दी से जाके डब्बा खोल के मैं 15 एंटीडेप्रेसेंट खा लेता हूँ. I'm not doing that. So it's typically like a hypothyroid person needs a thyroid tablet every morning, like a hypertensive is needing an antihypertensive every morning. Similarly, vitamin C is a person, some chemical, a defined dose for a defined period of time. And if he's taking antidepressant for 10 years, I would suggest him to be a psychiatrist.
So I think from the audience, if anyone would like to share their views, if they are in the field of addiction, any specific intervention strategies, or any specific effective model that has come out of dealing with addiction? Anyone can share the experience with the work of this one person from the Northeast, one student from Northeast, he is asking about the innovative intervention strategies that is effective in working with the addiction. Anyone from the audience, any seniors or any faculty members can help us?
I am a counselor. I am coming from down south, Coimbatore. I had an experience with a student and who was a very studious, with very nice cut off. I cannot any other what do we say theory or anything. The power of the parents. Appreciate that. When I saw her as a powerful mother, I wanted to share in this forum because sometimes unique, even each client is very unique. Which varies all are very generalized, and sometimes we have to take care of the specific need of the person or the client. Sometimes mothers, parents, or friends, or siblings, even a counselor, therapist, or a mentor, faculty member, plays a very vital role in adolescent life. That I wanted to register here in this forum. Thank you for me. I took the opportunity. Thank you for giving me.
Yeah, most welcome. Yeah, thank you, ma'am. Yeah, anyone, Convener sir, Himanshu sir, Sanka ma'am, anyone there, they want to contribute something, or shall we conclude the session? Anyone?
So this is
Introduce
Nilesh, sir.
yourself. Yeah.
So this is Nilesh. I'm a PhD scholar under Dr. Arif. And, so I'm working on the field of addiction and youth. So share my experiences and contribute. We talked about the addiction and how the adolescents are stuck and how they are going into the addiction. But there are other things which we need to discuss. Is that mostly we focus on the problem behavior, where the risk factors are contributing enhance the problem behavior. If we discuss or if we it will be the nice idea to deal with the adolescent problem. We to see that as a problematic, showing a problematic behavior. If we are doing the problematic behavior is coming from where? So it is coming from this is how in their childhood, in their family, person, the parents or their good family, then mostly on their behavior. So the discuss the experiences having with family members, and checking on their behavior. So the parents will the difference of the identity crisis to their unhealthy coping style. So that's why it is one of the why going to see substance which is based on the principles of model. They colleagues have developed the 5-step method to work with the family members. They basically work on they explore the experiences of the family about the family person's behavior, then how it was physical and psychological problems there also assessing the unhealthy and them to educate them about the giving information about and its plus and minus points and how we can deal with it and also to
the village, you want to tell that there's a five-step model for family intervention, right? Okay, thank you very much. Before going to Prashant for vote of thanks, I request Bakhla sir to please conclude the session, sir.
Okay, first of all, it's already quite late. And as we know, the topic itself, or in fact, addiction psychiatry, in fact, it is itself a specialty, and people doing super specialty course after MD. So, addiction psychiatry is a very big and broad topic. So, it is very difficult to compile, but even all three speakers have done very well, and I thank them. There are certain very few issues like as, as Vijay has talked about some biological underpinnings, some circuits and neurotransmitters and neurodevelopmental evolution. But these things does not directly develop to addiction. Usually, this biological underpinning develops to some personal deficiencies, behavioral deficiencies, like you can scale it to deficit in self-efficacy or emotional regulation, what I was just done. So there are lots of psychological deficits that has been reduced, and those psychological interpersonal deficits leads to various social deficits like socialization, refusal skill, those kind of things. So those are not directly linked, but those are basically कई बार हम लोग कहते हैं वो अंडा और मुर्गी वाला कंसेप्ट कि कौन पहले आया और किसको तो ये अल्टीमेटली एक ससेप्टिबिलिटी या रिस्क फैक्टर्स को जनरेट करता है जो कि एडिक्शन को लीड कर सकता है ऐसा जरूरी नहीं कि ये बिल्कुल लीड ही दूसरी चीज इसमें ये है कि अगर हम लोग इंटरवेंशन की बात करें तो दो लेवल पे प्रिवेंशन के लेवल पे या ट्रीटमेंट के लेवल पे जब हम लोग बात करेंगे तो बेसिकली दो चीजें समझनी होती है कि हम लोग कहाँ किसको हर इंडिविजुअल अपने आप में रहते हैं किसको हम लोग कहाँ पकड़ सकते हैं कुछ लोगों को हम लोग बायोलॉजिकल डेफिसिट के साथ कैच कर सकते हैं शायद अगर वहाँ नहीं पकड़ पाते हैं वो बिल्कुल अप्रोच से बाहर है तो देन वी लुक फॉर द साइकोलॉजिकल डिफिसिट्स जो कि सेल्फ मैनेजमेंट इंटरपर्सनल रिलेशनशिप इश्यूज और अदर इश्यूज पे रिफ्लेक्ट हो सकता है अगर हम लोग वहाँ मॉडिफाई कर सकते हैं तो हम लोग वहाँ अप्रोच करते हैं चाहे वो प्रिवेंटिव मेजर हो चाहे वो थेरेप्यूटिक मेजर सिमिलरली सोशल स्किल या सोशल लेवल पे जब हम लोग अगर इंटरवेन कर सकते हैं तो ये हर इंडिविजुअल के लिए अलग अलग सिचुएशन अलग हो सकता है और ये बड़ा टेलर्ड ट्रीटमेंट प्लान एनीवे मुझे नहीं लगता है कि बहुत सारी चीजें इस एक वेबिनार में समाहित की जा सकती है आई थिंक इट्स गुड एफर्ट और फिर धीरे धीरे हम लोग इस पे और अगर आगे कुछ कुछ और इश्यूज को लेकर के अगर कंटिन्यू रखेंगे थैंक यू and again thank you to Manisha ma'am for the opportunity
Before going back again to Manisha ma'am, first of all I request Dr. Prashant to give a vote of thanks.
Thank you so much, sir. Thank you so it's a privilege for me giving the thanks for this webinar because Vijay sir is here, Bakhla sir is here, and my friend Giri is here, and Madam is here. So I'm very interested to hear about this topic. We are here at present now, these are all because of all of you. So it's my privilege to give the thanks. On the behalf of Department of Psychiatric Social Work, RINPAS, Ranchi, I express my sincere gratitude to our respected chairperson, Dr. Bakhla sir, who is the head of Department of Psychiatry, RIMS, Ranchi. Sir has spared his valuable time for us and given his specific and important words and grace us our program. Thank you so much, sir, for giving us splendid time. And when we moved to Dr. Vijay, sir, I have he is our guru. What we have learned to psychiatry, sir has some danda therapy is there, some so, thanks to Vijay sir, and sir has covered nicely about the biological parts of addiction. And when we talk about the things that before starting of the session, I told that sir, कोई question तो नहीं पूछने वाला है. Sir has told it, there is so much question. So yes, definitely sir has covered with a lot of questions. But at the last, we can say that sir has also given the answer of all the questions. And so thank you so much, sir, for giving such a nice, elaborative, and such a nice presentation to all of us, and giving enlightened to us. Uh, um, we move forward to Miss Ruchi Bapat ma'am. She's a consultant psychologist in Pune Hospital and Research Center Pune. Ma'am has given the very nice psychological impact of addiction. She has covered about the psychosocial risk, neurodevelopmental changes, and the factors associated with addiction. Ma'am has covered all the psychological aspects, what to do in this condition, like she has covered about the MAT, RPT, and so much things. And I think that it's a limited time frame, and in a limited time frame, she has covered a lot of things. So thank you so much, ma'am, for coming and giving us valuable input. Uh, uh, and when we talk about our Gaurav Giri, he is my good friend and my loving junior. He covered all the models and approaches of how the psychosocial impact is there in the addiction, and what are the approaches, how the family, psychosocial family approach is helpful in the addiction. So he has covered a lot of things in a very elaborative manner. Uh, Beyond that, there are some queries related to all the participant has asked, and all the three our respected speaker has covered all the things, and they have very beautifully explained the queries to all the participants. Uh, I would like to thank Dr. Arif sir, who has very beautifully moderated all the session, and and I would like also to thank to Dr. Muscat ma'am, who has given me the opportunity to say the thanks. As I told that thanks to you, ma'am, that you have mentored us and are in a capable position to say thanks. So thank you so much, ma'am, and for that organizing such a nice program. And it's a very interesting. And last but not least, our participant, so much respected seniors are there, like Govinda sir is there, Dr. Ajay sir is there, Dr. Nand Kumar sir is there, our friend Upendra Nupur ma'am is there, Swandapa ma'am is there. So much our respected senior, our friend, colleagues are there. So I would like to thank all of them for attending the webinar and participating in a very active manner. So so I have left. I'm very sorry for that. So at the end, thank you so much all of you for connecting with us and giving your valuable inputs. Thank you so much. Namaskar.
Thank you, Prashant. Now I'll move to Manisha ma'am for the final comment, ma'am.
What final comment? Thank you for conducting the session, Arif. I would like to really thank Vijay, Dr. Bakhla, Rucha, and Gaurav for giving us this opportunity to hear you all. It is really a very vast topic, and it cannot be covered in one session, in 1.5 hour session. I think we will definitely look upon your proposal, Dr. Bakhla, that we can continue more sessions. And Vijay, if you can cooperate this, and with your chairperson, definitely. And I can see a very active, the participation itself shows the what is the impact of the whole webinar. So the number of questions which I must, it shows that they were actively listening and actively participating throughout the webinar. So this is a very positive remark that it has really succeeded. We have really succeeded in our what we had planned. So it's really very I'm really thankful to each and one of you for giving us this wonderful feeling that we have been able to successfully complete this webinar at last. And thank you so much. And I could have seen number of participants also were more than 100. I don't know what was the number of participants in meeting, but here I was seeing that it was more than 100 participants in this particular meeting. So it itself gives that Vijay, you have really made it big. Thank you so much. I would request you to say that because time itself, it was 1.5 hours, so it's 8:15 now. So that the name says me, nobody is tired enough here listening to this academic platform. Thank you very much, each and every one of you.
Thank you.
Thank you. Thank you all of you once again. Thank you.